Welcome to Connecticut eHealth Podcast, educating, conversing, and connecting for better health. The Connecticut eHealth Podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, this is Tom Agresta. I'm a family physician and clinical informaticist at the University of Connecticut, and I'll be your host for this episode of the Connecticut eHealth Podcast. Today's guest is Dr. Alan Kaye, a Connecticut radiologist who has been advocating for image sharing throughout the state. His educational background includes a bachelor's in history of science and sociology of medicine from Harvard, a medical degree from the UConn School of Medicine. He completed a radiology residency at the University of Pennsylvania and practiced for over 30 years before recently retiring from clinical work. Dr. Kaye is also the past president of the American College of Radiology and the chairman of the Department of Radiology for Bridgeport Hospital. In addition, he provides guidance to our state's Office of Health Strategy through seats on the OHS Healthcare Cabinet and Health IT Advisory Council. It's a pleasure to ask you today, Alan, to join us on this show.
My pleasure, Tom. I'm very happy that you've asked me to do this, and thanks for the opportunity to help you in your efforts on behalf of the people of our state and our patients.
Yes, it's all about improving the care for our patients. And that's, I think, your volunteer efforts at the Office of Health Strategy and the Healthcare IT Advisory Council, or HITAC as it's affectionately known, has really demonstrated your willingness to kind of help move our state forward.
Thank you. Thank you.
So Alan, tell us a little bit about yourself, kind of a little bit of a history of your career and how you became interested in your sort of health IT to improve clinical care.
I would add one thing to your introduction, and that is that I'm now retired from clinical practice of radiology, and that practice included managing advanced radiology, which operates numerous outpatient radiology offices in the southwest part of our state. And as such, we took care of patients who had relationships with hospitals and doctors who had interrelationships with many different hospitals and other doctors, and that have different IT infrastructures, which presented significant problems in getting information to and from. They had different electronic health records, et cetera. So when you're a radiology practice, we do imaging for all types of patients from all sorts of illnesses and maladies and different types of subspecialty practices. It touches basically almost every aspect of the healthcare continuum: inpatients, outpatients, every medical specialty. And the effectiveness of what we do is really dependent on us receiving the best and the most timely information about every patient, and then communicating our information outbound to the treating physicians and having it preserved for future reference in the patient's permanent electronic health record. So information is really what we do, and radiology is nothing if not an information service. And the better the flow of availability of our information, the better care of our patients.
Yeah, that's so true, Alan. And I can recall myself at several points having knee surgery and having to have MRIs done of my knee, and even in one setting having an MRI done of my knee when a diagnosis was being made, and then having to what I would call, carried over via my sneakers.
Yeah, sneaker net.
Sneaker net, exactly. From one place to another, just to have the orthopedic surgery doctor review it and say, yeah, you need surgery. That wasn't that long ago. That was only 12 years ago.
Right.
Tell us a little bit about what's changed in that time frame from your perspective in terms of our ability to share and engage in that kind of with radiologists and radiology images, et cetera.
Sure, Tom. A lot's changed. 12 years ago, I assume the images you picked up was on a DVD or something like that that you took that you carried, or did you carry the actual full envelope with all the films? Let's assume it's a DVD.
No, it was an envelope with all the films. My second time that I had my other knee, I'm a little prone to injuries, as you can tell.
Hmm.
The second time I had my other knee dealt with, it was on a DVD.
Okay, so let's forget about the antiquated, heavy 100 films that you had to carry, because that presented its own problems for anybody that wanted to look at them. The nice part about digitization of imaging and the ability to present it on other media is that you don't have to do that anymore. And what it does is it sort of democratizes the whole process. Anybody with that DVD can put it into their, well, assuming that it works, which we'll get to, can put it into their slot on their computer and look at the images, which saves a ton of time, and transport and film costs money. There's silver in film, actually. So it saves a lot. So DVDs have been a staple for a long time. And so a lot has changed that has allowed much more efficient communication of the information. But the process of DVDs is not always that reliable. It also costs money, up to, I think I've seen some studies that show $10 per DVD by some estimate, because of not only the material, but the time it takes for staff to do it. And then why don't we say, not completely reliable ability of different computers to look at it. So that's so the technology has advanced tremendously. Unfortunately, the technology has enabled a lot of things, but it's not necessarily getting into as broad, as wide a use. We've now got electronic health records, which are ubiquitous, broadband, the cloud. These are really enablers of the flow of information. There are some more esoteric advances and processes that have also enabled interoperability of different technologies. And Tom, I know you know that, but that just means that one iteration of a technology can talk to a similar but not completely the same constructed or engineered technology. And if you look at how healthcare to a certain extent is behind other industries, think about streaming services. The movies that we watch on our TV anytime we want from the cloud or over cable. They're examples of the ease of which information can flow. And it is available in radiology in terms of it can be done, but the implementation has really lagged. So technology's advanced tremendously. We'll talk a little bit, I'm sure, about the different types of ways that it can be done. But unfortunately, for all practical purposes, DVDs are still the king. And there's a whole movement afoot to say, ditch the disc because of the cost and a lack of reliability and interoperability.
That's a great movement. We'll have to remember that. Ditch the disc. Maybe we'll title this particular episode "Ditch the Disc." So you have been an advocate for electronic exchange in radiology and other images as well. Not just the radiology images through health information exchange. Can you share a little bit of examples from places where it's being done and done well, and what the benefit has been to the stakeholders involved?
Yes, I wish there were more. I can give you examples of how we've done how it hasn't worked and some workarounds, and then maybe we could talk about some of the ways that it is working to a limited extent. So Connecticut is a beautiful state. A lot of towns with their own characters, and in my part of the state, where I-95 runs through, you can go on I-95 and see multiple billboards telling you about the wonderful hospitals in each town. I'd say in Southwest Connecticut, hospitals are less than 10 miles from each other on average. If you took all the hospitals and divided by the length of 95. Patients can live and work in proximity to different hospitals and spend most of their day near one hospital and most of their day near one that's not really too far away, but get care dependent on where they happen to be at that time, particularly with respect to emergencies. So they can show up at one hospital one day and another on another day, and this really happens a lot. So as an example, one day I was on the ultrasound department at one of the hospitals I worked at, and the emergency doctor called and requested that we do an ultrasound scan to help with the diagnosis of a patient that didn't have a clear clearly defined diagnosis. And it's always good practice as a radiologist. The first thing we're taught is to look at if there are prior tests and compare them the patient may have had relative to that condition. So when this patient arrived at the radiology department, we asked the patient about his history, and he told us he'd been at the other hospital in town, emergency room, just the day before for the same condition, but his symptoms had gotten worse. So only by luck that we happened to provide the imaging services at both hospitals in the town of Bridgeport did we have accessible to us the images, the actual infrastructure, the programs to view from what was one hospital to another. It wasn't anything necessarily that the hospitals had done officially or arranged with each other. It was just because we happened to have access to both. So when the patient said they'd been at the hospital across town the next day before, I looked and saw if there were any imaging studies. And indeed, there was an ultrasound just from the day before, unbeknownst to the emergency room physician. I'm not sure exactly what knowledge the patient had about what type of exam, but it was a normal ultrasound examination. And so after talking to the patient, we thought maybe there was, the role for a CAT scan there. We called the emergency physician, and of course the physician said, please go ahead. And we did. And in fact, the patient had a ruptured appendicitis with pus in his belly. And of course, that requires immediate treatment. In this case, it was intravenous antibiotics to stabilize the patient and things like that. So there was a case of a fortuitous ability to see what was done somewhere else, which didn't really exist at all at that time, other than if the patient happened to bring a DVD with him. And that's an example of how having access to timely information would have made a difference, not to mention another duplicative test, which would have delayed the diagnosis. And not only that, cost more money. And so there's a good example. But, a perhaps much more frequent example, and on a population basis, even more important, is there many people have chronic diseases of which they have sought and received care at multiple places during the course of their illness. And, think about things like diabetes, blood sugar, control level, ability to control the diabetes, anticoagulant medications, which affect just about everything in healthcare. And then there's, a history of cancer, that the extent of the cancer and what it might be causing. All those things would be important to know, not only for imaging, and we'll get into this a little bit later, but also in, especially in imaging, with respect to if I'm going to be doing a test on the patient, I want to know the clinical context. So, many more examples relating to quality and cost of care. But another one is, most imaging now is outpatient. And so the outpatient offices that we service, which were not necessarily affiliated with the hospital in the town in which they're located, there was not an ability other than having to carry a DVD around with them to take to their surgeon or take to the hospital where they're having surgery. And, your surgeon probably, when they did the surgery, looked at the images while they were doing the surgery to help guide them. And certainly with other things, abdomen, brain, spine, they generally have the images on the screen when they're doing the surgery. And if the hospital doesn't have the ability to access those images, and there's a glitch with the DVDs, which happens, you now have a patient who doesn't have images available to their surgeon while they're doing the surgery. So all these things bespeak for good patient care, not to mention the cost and the time and all those other things.
Yeah, those are wonderful examples, Alan. And, it does speak to sort of what an ideal situation might be. And could you describe, if you were to think about, sort of an ideal image sharing infrastructure, what would it look like? What would be the qualities of an image sharing process, maybe through a health information exchange or other ways that would make it successful?
Sure. How many hours do we have for this podcast? I don't have time for a complete answer on this one, but I've been it long enough to know that, and you've probably heard me say this in some of the meetings we've shared together, the enemy of good is perfect. So let me take a swipe at a couple of things that I think are really essential. First, there's need to have and there's good to have, and so the best practice in this case would be if it's integrated with the rest of the electronic health record. By that I mean to say that when somebody's using the electronic health record, that the imaging is just a part of the same application and one click away from the other information, because they're all connected. I mean, to know patient has a heart condition and not know, that that the pulmonary vessels are congested, or that there's a pleural effusion associated, that they're in failure, or whether it's a spine patient with a pain down their leg from sciatica from a compressed nerve, and not have the images there, or vice versa, having imaging that shows something, but that might be on the other side from where the patient has symptoms. The knowledge of every physician or treating individual or treating provider type is best done if it has all of the information there. So ideally, it would be part of the EHR and easily accessible with as few clicks as possible. Another part is, patient privacy, and patient will need to consent to this and consent to have this. And so otherwise, once the patient consents, or in my preference would be not, patient doesn't opt out, that it's an opt-in unless the patient decides not to. I don't have time to get into that, but that it would be automatically accessible to every caregiver to that patient. Because there's, as we said, not only unique to Connecticut, but there's patients see different providers for different things, ancillary, what we might call ancillary providers of care, and things like that. So we talk about physicians, of course, and hospitals, of course, and ancillary caregivers, of course, but then pharmacies, laboratories, extended care facilities, and things like that. It should be automatically accessible wherever that patient happens to be at that time. And I'm a big fan of teeth. You can have regulations and laws, but if there are no teeth to them, then compliance may not be ideal. So I think provider participation should be mandated either by law or by other regulation, or by some sort of incentivization or disincentivization not to do it, and it should be enforced. We have a special role in this world as healthcare providers, and we are subsidized by the taxpayer. So I think we have an obligation. We should require to have an obligation to do these things.
So you described some really interesting things, and as a primary care clinician, I often find it very useful when I'm meeting with a patient, and especially if I'm talking about a complex issue, a recurrence of cancer, or things that even another, specialist may be providing, that I can pull up the image and show the patient what they didn't understand in their prior meeting, and they really appreciate that ability to do that. And there are many, I would say, unaffiliated primary care clinicians and other specialists in our state. We just don't have access to all the imaging that is done for a patient. So I think you bring up some really interesting points. And you really described what a perfect image exchange workflow might be like. In other words, it's duly embedded, but you also really brought up the enemy of the good and not being perfect. So what would you want as a starting point in our state?
Well, I think we've embarked on that by having one of the early prioritized use cases for our state mandated HIE to include image sharing. So so now we just have to figure out the right vehicle for it, and I think we have a good one. I've yet to see it put into practice, actually in practice, but I understand that's imminent, and that's good. So I think with respect to imaging, I could give you an example of another example of how image sharing, is available but not necessarily used in the best way. And you have 5 minutes for me to tell you about this one?
Sure, absolutely.
Okay, so this is fairly recent. I'm talking about within the past 2 or 3 months. A friend of mine had a problem with his foot, which caused him to fall. And we won't get into the consequences of that, but it turns out that he had a potential diagnosis of osteomyelitis of his foot, and he had imaging, which all needed to be correlated at the orthopedist office, 2 sets of X-rays at orthopedist offices, a MRI scan at a local hospital, a nuclear medicine study at a particular imaging facility very familiar to me, and then was admitted to a hospital for potential treatment. The two hospitals, each of those things required some degree of logistical complexity to get them to the next treating physician and the next treating hospital. The two hospitals happened to participate in one of the existing private company vendor image sharing. And it cost them a fair amount of money to do it. So I said, we're golden. We're going to get it over there. We've got all the outside imaging, the non-institutional imaging in one spot with the patient, made sure that he had the DVDs with him. And now we're golden. We're just going to have the hospital system that has it, send it to the hospital that has that participates in the image sharing. Well, it was great that the hospital had been paying for this subscription, but the staff at the hospital did not know how to send it out. They could take them in, but they didn't know how to send them out. So it ended up being, and this happened to be, of course, Friday afternoon. And so it ended up taking till Monday till we sneaker netted a DVD over there instead of having it be immediately available. And 3 more days go by before the potential institution of the treatment for osteomyelitis. Fortunately, it turns out he did not have osteomyelitis, but again, it could have been it could have been otherwise. So that's the kind of thing. We not only need to subscribe to this HIE, not only to subscribe to these image sharing and other information sharing services, we need to invest the time in training, educating our staff about how important it is, and training them how to use it. And so you can go, what do they call it? The last mile. You just have to do the last mile in addition to laying the cable along the side of the I-95. You've got to get it to my and your homes.
Yeah, so this is a great story about some of the additional things we need to consider. We're going to take a brief pause here, and when we come back, we're going to talk much more specifically about our actual HIE, Connie, and some of the plans that are underway and some of your sort of words of wisdom for them. So let's take a brief pause for our sponsor.
We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode.
So as we come back into our discussion, Alan, it's important for us to point out that actually our state health information exchange, Connie, as it's known, actually just began rolling out image sharing in a pilot fashion with a few organizations. And you started to talk a little bit about how optimal workflows might be and how we might do image sharing in an effective way. And you started to talk a little bit about what other value adds could be done. But could you further expand on that and talk a little bit about what the HIE should do to help improve the value for providers and for patients?
Sure, Tom. I kind of partially answered that in previous discussion, but there are really substantial abilities that we can bring added value to this. And that was all part of that when in 2014, 2015, when we began advocating for this, that we helped to garner support because, there are a lot of, you talked about my major in college. There are a lot of social implications of care. And one of those is the cost of care. Healthcare in this country costs a lot of money, and we want to make sure when you spend a lot of money, you want to make sure you get value for it. So important part of the data that we will accumulate and hopefully be able to analyze is the public health reporting. I mean, imagine how great that would have been to have all those electronic health records analyzable during the depths of the COVID crisis that we just went through. So there's public health reporting, there's improving access to care. What populations are we missing out on? What locations are being used? Where should we place our resources so that we can get to more of the population, not even considering ones that are underserved. There's research in patterns of care so that we can improve the effectiveness. It'll be for our University of Connecticut Health Center and the people that work there. There'll be a lot of fodder for research. So So, those are the kinds of benefits, of things that can bring added benefit. But I do want to emphasize, Tom, and you've heard me say this before, that I view these as really secondary to the goal of facilitation of care and communication between patients and among and between providers and their patients. So, they're all fraught, all of these other things are fraught with concern for privacy, regulation, politics, et cetera. And every time we expand the use case, we have another constituency that is going to want to have a say, either pro or con. And that can end up delaying things. So I've always been an advocate for compartmentalizing the clinical aspects of it and the public health aspects of it. And so I'm just you've given me an opportunity to have another platform on which to express this.
Yeah, I think what you're talking about is, testing out and making sure we do incremental benefit, right?
Right.
And that we understand the pros and cons and risks and benefits, but still move forward nonetheless with, where we can, what we can. And I think in imaging exchange and radiology in particular, there are good technical standards that permit us to share images and view them in different systems. There's the DICOM imaging standard, which affords interoperability a lot better than many other segments of even the healthcare technology realm. And so that really gives us an opportunity to incrementally move forward with image sharing between organizations. Even in Connie's case, they're using a technology that permits one organization to almost automatically share, unless the patient opts out, to almost automatically share the images that are taken in one facility, and another facility has a treating relationship with that patient. If they show up like your friend did, to be able to automatically download and utilize that imaging in their own system for purposes of the OR or for other things like that. So I think we're heading into this seamless capacity to share radiology images. I don't think the same is true yet for pathology images or images of the skin, dermatology images, but I think those things are also on the pathway to being available down the road.
That's great. That's what we want.
And can you tell me a little bit about what would your advice be to organizations that are considering starting to share images or starting to have access to the images? What would you advise their leadership and their medical staff, for example?
Well, I think I talked about that a little bit, well, more than a little bit maybe, about that subscribing just isn't quite enough. It needs to be used, and the training of the staff. You can have it, you can own it. I mean, all of us own things that we don't use as much as we probably should, and so we need to make sure that it becomes institutionalized within each venue, that it's done that way. The other is that, to a certain extent, the siloization of electronic data has been due to two things. One is just the resources available to provide the information to someone other than within your own circle. And the other is the competitive potential disadvantage or leakage of patients from your institution that might occur if you enable patients to go outside. And that's been a very important thing, both not only in Connecticut but nationally. So there is now information blocking legislation in Congress through the Cures Act that basically makes it a criminal violation to withhold imaging. Now, that's a pretty draconian thing, but it has gotten the attention of the hospitals around the country. It's mostly hospitals, but there are other large healthcare institutions that might have engaged in the practice. So be aware of that, because now we've got outside. Anytime you do things that aren't necessarily according to Hoyle, you start to get influence from entities that may not appreciate what we do as well as we would like. So I think we have to get past the competitive aspect of it and realize that that information sharing is no longer something that is going to that can be used to keep walls around us.
Yeah, you bring up a really good point, and that is that if we're truly kind of moving towards value-based healthcare where there's more collaboration and less competition, the ability to sort of all provide value and gain from the value is, perhaps a motivating factor. I'll raise the question that you kind of created in my mind about that, and that is that, because of the way we've structured healthcare, we even have like independent radiology practices that have existed. And can you talk a little bit about the what's in it for them if they were to hook up with the HIE, and how they might benefit from this rather than perceive it as a risk to themselves?
Yeah, whenever we do this, I sort of always start at these things at what's the right thing to do. We do pretty well as physicians. Radiologists do well, but pretty much many physicians do well enough. And I always subscribe to this thing: do good, do well. It was my first screensaver that they used to have that went across the screen. And so the first thing is patient care. And as a radiologist who wants to take care of a patient, it's frustrating to do an unnecessary exam, or to do an exam where you're told the wrong history or you're not given an adequate history. And so, what's in it for the radiologist? Number one is that you get better job satisfaction. You feel like you're doing what needs to be done, and you make a judgment beforehand about which test needs to be done and whether you're doing the right thing. And so, to me, that's where you start. Okay. Now, of course, there are other considerations like how efficient can I be, and certainly it's much more efficient to have your images shared with somebody than to have to receive them in a DVD that may have been mailed, and then I have to make a phone call to them afterwards when they want to know what the exam showed. So it saves the radiologist time, it saves your customers, which are patients and referring physicians, time. So that's one of the things. Another, what's for the independent imaging centers, this is something that they absolutely need and that we needed. In my practice, we developed our own technology to overcome some of the resistance on the parts of others to use our information. In fact, we even gave it to the patients, and we had a patient who needed some care, and I got an email from the patient's physician who was vacationing in Europe, because the patient knew where there's something wrong, and the physician got the report and was able to see the exam on her iPad in a foreign country, and we communicated about that. And so there's a tremendous amount of job satisfaction, but it also garners goodwill on the part of your two main customers, who are physicians, referring physicians, and the patients who you serve. So it's it's one of those things where you make an investment in something and it shows it pays off in many ways.
Yeah, you bring up an interesting point, and that is that neither patients nor physicians these days are necessarily in the region that they took their radiology exam in, right? I mean, the patients that we serve in Connecticut often not only travel throughout the world, but they're often 6 months or 3 months in Florida or elsewhere.
Mm-hmm.
And I can tell you that the benefit of something like our HIE is that because we're sharing through a multi-state HIE arrangement, it's very plausible in the very near future that the images could be shared with a treating physician in another state as well. So that could actually provide a much more effective mechanism for finding out if that cancer has spread or things have happened in the interim time frame from the prior radiology exam.
Mm-hmm. Mm-hmm. But again, it's Tom, you and I have discussed this. What I'm about to say. Pharmacies. I mean, medication errors are big sources of error, and pharmacies need to be part of this. Patients, patients need to have medications while they're away. But not only that, a uniform pharmacy medication reconciliation document is very important, so that the patients aren't given the wrong kind of medication that might interfere with existing ones, or interfere with their existing diagnoses. So I mean, we're at the beginning, and I think a somewhat delayed beginning. Not Connecticut, but the world. Not only Connecticut, the world is of a real revolution accessibility of care and catching errors and preventing errors and making things better and preventing bad things from happening.
Those are wonderful words of wisdom. Can you share any final statements or words of wisdom? Because I think it is good for us to leave on a positive note, but share what else you have to share with our listeners.
Well, I thought that was a pretty good ending, but I hadn't thought about that in advance. But it's just what we're about. It's what we're about. This new technology has a lot of new. I'm now I have another career. I'm a chief medical officer for a startup company in California that's meant to. The whole purpose is to enhance the efficiency of information flow, starting with radiology. Basically, it's going to be starting it for a while in radiology. Information flow, efficiency of radiologists, intake of information and communication of information, but also processing of it in a way that allows them to reduce burnout and things like that. So the work will never be done, will never be finished, and there's always a way to do it better.
Right, and I think the other part is that we all have a part to play.
Oh, absolutely. Even though I used to tell our people who work for us that nobody could do what they do without the task performed by everybody else in the organization, and that goes from doctor to nurse to radiology technologist to scheduler to front desk assistant to people who clean for us and maintain the sanitation in the office and the department. So every part of us needs to pitch in here, and information flow and technology affect every one of our jobs.
Absolutely wonderful. All right, Alan, I really do appreciate the time that we've spent together today, and look forward to sharing with you again in the future as we kind of make these incremental steps and improvements in image exchange, but also other forms of health information exchange as we've discussed over time.
Great. Thanks, Tom, for what you do. I've seen the effectiveness of your input and also your sharing of information and dissemination of it. So thanks a lot, and let's keep going.
All right. Take care now.
All right. Take care. Thanks.
As always, wishing you the best of health. Your host, Tom Agresta.